The problem is that you guys, like me, are facing what I call the medical pharmaceutical industry pressure. Because of course, even you're reading all these papers, all these works, research, you don't have time enough to read all these biomaterial. And I did this last year when I was in Marrakesh for a congress. And it was just after the lecture of my friend Essam Nusri from USC in California. And this is what I get on internet in 4 minutes. 4 minutes. And you probably have the same result like me. Just tap on your computer, biomaterial, xenograft, allografts, whatever. And you probably recognize some of your product, the product you use in your clinics. Again, the main question is, can we do without? Can we have the same outcomes, at least, in not using these biomaterials? Then the question is, again, are these xenografts secure? Are they secure? And I got this publication from my friend Nusri, which is leading the period post-graduation in USC. And he published this, it's a systematic review, the risk of prion disease transmission through bovine derivated bone substitutes. And the conclusion was that the review indicates that the bovine derivated biomaterial may carry a risk of BSC prion transmission to patient. What is this? Creutzfeldt-Jakob. Creutzfeldt-Jakob. What happened in medicine when there's a risk? You suspend it. So I went on research of some papers that was publicated. And I got this in International Orthopedics, which is the major publication in orthopedics. And that was published in 2012. And the conclusion, although prion disease transmission by bovine bone, xenograft are not being observed. Okay, not being observed. But the risk is unknown, and avoid the use of bovine xenograft. That means that in orthopedic, they recommend it and they ban the xenograft. What about allografts? Allografts, I've got two different studies here. The first one that was published last year was conducted in monkeys. And on monkeys, the HIV become the SIV. But it's almost the same trial. And what is the conclusion? The results show that the SIV, meaning HIV for monkeys, can be transmitted in bone allograft procedures. Can be transmitted. The second paper, the conclusion is for massive bone allograft, the risk of bacterial infection is approximately 12%. What they consider as a massive bone allograft in orthopedic is a wide amount of graft. That means for a leg or for a shoulder or whatever. And for a non-massive allograft procedure, mean our procedure pre-implant, the risk is 0.7, almost 1%. The risk is there. Well, I can show you different reviews talking about the same topic. We don't want to waste our time, but just let me give you this one. The conclusion: the next new virus or unknown pathogen is always on the horizon. Just think about Ebola. And maybe a lot of us are forgetting some aspect of that 35 years ago we had numerous individuals that were infected by the HIV before anyone knew about the AIDS and how it was transmitted. So the next virus is always at the horizon. Another publication on orthopedic research. And what I wanted to show you is that there are a lot of publications showing that there's a risk. Why in some specialties like orthopedic, they banned some products and we're still using them. But the main issue is that if we can have the same results without using them, why not going this way? In implantology, we all know that the first key to success is primary stability, right? And this primary stability as a fundamental parameter is represented by three major different aspects. Because of the density of the bone, because of the design of the implant, the properties of this implant, and because of the procedures. But all of them, all of these three aspects, are interactive altogether to give different procedures. But we have all the time to think about one of each of all. It means that it's not because you're using this implant or this type that you will end up by a good result. It's not because you're using one kind of procedure that you will have a nice outcome. It's not because you're using a nice implant and a good procedure, and because you have a weak bone, that you will end up by a good stability and an implant that is predictable in the long term. So first aspect, anatomy and biomechanics. Actually, my intention here is not giving you a course or a lecture in anatomy or biomechanics, but probably all of you are like me. Sometimes we forget some basic aspect. And I want just to refresh you some basic things about the constitution of the bone, both of made by the cortical, this tense bone, and this cancellous bone. And we know that the cortical bone, this tense bone, can be compressed, cannot be compressed, cannot be stressed. Otherwise, we know that, and because of the vascularity aspect of this cortical bone, we will end up by resorption. But contrary, the biomechanical aspect of this cancellous bone